Okay, so we are going to start our class. So this is the synopsis which we are going to study about definition, pathophysiology, risk factors and screening criteria, classification plus disease AROP, management, and regression, reactivation, lead sequelae of ROP. So definition. So retinopathy of prematurity is a proliferative retinal vascular disorder. It is a disorder of the development of the retinal blood vessels in premature babies. Originally, it was known as retrodental fibroplasia by Terry 1952, who related it with premature birth. The term ROP was coined by Heath in 1951, and incidence in India is 38 to 52% in low birth weight infants. And there were three epidemics of ROP in 1940 and 50, 1970s, and mid 1990s. So this is very important development of retinal vasculature. So choroid development starts by 6 weeks of gestation and completes by 22 weeks of gestation. Retina, the development starts by 16 weeks and starts from the optic disc, and nasal ora is completed by 32 to 36 weeks, and temporal ora is completed by 40 weeks. So risk factors for ROP, American Academy of Pediatrics guidelines are different, and in Indian scenario it is different. So we will mainly follow the Indian scenario. Low birth weight, less than 1700 grams, as you all told. Young gestation age, less than 34 to 35 weeks of gestation, and exposed to oxygen more than 30 days. An infant born at 28 weeks and weighing less than 1200 grams are at higher risk of developing severe form. Other risk factors are postnatal factors like sepsis, blood transfusion, intraventricular hemorrhage, necrotizing enterocolitis, and slow weight gain. These are some other risk factors. These are like respiratory distress syndrome, bronchopulmonary dysplasia, CNS injuries, hyperglycemia, proteinuria. So pathophysiology. First of all, what is normal? So vasculogenesis or de novo formation of vessels from precursor endothelial cells before and at the age at about 14 to 16 weeks of gestation it will occur, and vascularization of the posterior wall through 22 weeks of gestation. So there are the endothelial progenitor cells will coalesce and form lumen and vasculogenic networks, and blood vessel formation will occur. Angiogenesis, it occurs via the budding from the existing vessels. So this is the blood vessel, and then vessel sprouting will occur, formation of the new blood vessel. So to extend the retinal vessels to the periphery and to other plexi. So effect of oxygen on immature retina. So there are two stages of pathophysiology: primary stage of retinal vasoconstriction and vascular occlusion, and secondary stage of retinal neovascularization. So normally when there is in utero, the IGF levels and VEGF levels will be in normal range and normal vessel growth will occur. But when there is a premature birth, there is an immature retina. But due to the premature birth and low birth weight, we will provide the baby will be provided with oxygenation and all that. So IGF levels will decrease and VGF level also will decrease. So because this is a stage of hyperoxia, because retinal vessels means it will think that there is a lot of oxygen and it will not, the vessels will not proliferate. When when the baby is not given any oxygen after the initial resuscitation, then there is a maturing retina, but there is hypoxia. So there is a slow IGF increase and EGF is increased much more because there should be some vascularization, and that causes neovascularization and proliferative retinopathy and retinal detachment. IGF will increase, but it will not increase as much as VEGF. There should always be a balance between IGF and VEGF. So VEGF will increase much more than screening. Screening also we will focus mainly on Indian scenario only. So that only, that birth weight less than 1700 gram, gestational age at birth 34 to 35 weeks or less, exposed to oxygen for more than 30 days, infants born at 28 weeks and weighing less than 1200 grams, that is the same only, and presence of other factors such as respiratory distress syndrome, sepsis, multiple blood transfusions are required. In case of screening, should also be considered in the babies more than 37 weeks gestation or 1700 gram birth weight in this all cases, like respiratory distress syndrome, sepsis, and all that. So if other these all are also present, then we should also do screening in all these patients. Not, and there is a very good article by Lingam Gopal sir and others on program planning and screening strategy in retinopathy of prematurity, which is very easy to understand on this when we will do screening and what phase and all that. So screening conditions, the infant, uh, infant should be screened within 4 weeks if gestation age is more than 28 weeks, or when the gestation age is less than 28 weeks, or birth weight is less than 1200 grams, then within 2 to 3 weeks is okay. So feed child 1 hour before the exam. ROP drops, the recommended concentration is 0.5 to 1% tropicamide and 2.5% phenylephrine eye drops. One drop should be instilled 2 to 3 times, 10 to 15 minutes apart. And the perform punctal occlusion and wipe excess drops. Use a sterile Alfonso speculum. I'll show what is Alfonso speculum. To retract the eyelids and wire vectors for gentle depression or for the examination. Retinal imaging via wide field fundus camera and telescreening. That is okay. So dilution of eye drops. This is very important. In India, we have only 10% phenylephrine eye drops or 5%. So we need to dilute them in 1:4 ratio in carboxymethylcellulose or commercially available distilled water. So effect will last for 30 to 40 minutes. So final composition of ROP drops will be 0.5 to 1% tropicamide and 2.5% phenylephrine. This is tropicacil plus. Anyone knows the concentration for this? What is the tropicamide concentration, phenylephrine concentration? 0.8 is the tropicamide concentration and 2.5% is phenylephrine. Sorry, 5% is the phenylephrine. This is WinDrop. So what is WinDrop? WinDrop is online algorithm which will tell us, which identifies the infants with the highest risk of developing ROP as early as 6 weeks before the onset of symptoms based on the birth weight, postnatal weight gain, levels of IGF-1 and IGF binding proteins, and among others. So mainly there is birth weight and postnatal weight gain. Every week we have to test what is the weight gain, and then we will apply the weights in this WinDrop algorithm, and then we will know if there is a high risk for if the baby is high risk for ROP. Then prevention. So resuscitation if possible, avoid 100% O2, and supplementation no level is safe. Optimal PaO2 level should be 40 to 80 mmHg. Low O2 saturation in first weeks and high more than 32 weeks of post-menstrual age, and decrease the risk of severe ROP. But the concern is that lung disease and abnormal brain develop, hypoxic ischemic encephalopathy and all that may occur. So, and aggressive parenteral nutrition has reduced the risk of less severe ROP but not severe ROP. Supplementation with vitamin A and vitamin E, inositol, and breast milk also appears to reduce the incidence of ROP, but only in the observational studies. So, classification plus disease ROP. So, international classification of ROP was introduced in 1984 and revised in 2005 and most recently in 2021. The four defining concepts of ROP are zone or location of the environment, extent of the disease severity or stage, and plus disease is present or not. So, according to ICROP 3, locations or zone. So, zone 1, first of all, the concentric zones are centered around the optic disc, not the macula. So, this is the macula and this is the optic disc. So, zone 1 is the imaginary circle with the radius twice the distance between the center of the macula and disc. Okay, so this one will be twice the distance between the optic disc and macula. Zone 2 from the edge of the zone 1. Okay, zone 2 from the edge of the zone 1, it extends with the radius that extends from center of the disc to the nasal aura. Okay, and posterior zone 2, it is 2 disc diameter from the border of the zone 1, that is known as posterior zone 2. And zone 3, it is a residual temporal crescent anterior to zone 2. This one is entirely zone 3. Okay. And extent of disease, it is based on clock hour positions. Like it is divided in 30 sectors with boundaries along the clock hour positions, like 1 o'clock, 2 o'clock, 12 o'clock. Then staging severity. So stage 1 is the demarcation line, stage 2 is the ridge, stage 3 is extraretinal fibrovascular proliferation, stage 4 is partial retinal detachment, stage 5 is total retinal detachment, and stage there is a pre-plus disease, and aggressive ROP. So what is a notch? Incursion by a ROP lesion of 1 to 2 clock hours into more posterior zone secondary to notch. So means the ROP lesion will extend into the more posterior zone. Like if it is in zone 2, then it will also extend into zone 1. So what is demarcation line? A thin, flat, tortuous gray-white line running roughly parallel with the ora serrata at a junction of vascular and avascular retina. It is more prominent in temporal periphery. I mentioned this. There is a 28D lens. So whatever, whenever you are able to see a disc in a 28 degree length, whatever zone it will cover, that will be zone 1 only. Okay, you understand that? Whatever you will see, if you are able to see the disc margin, then it will cover the, it will be in zone 1 only, not, and it will not go outside. So that will be easier for classification. Ridge, that is the second stage. It arises in the region of demarcation line, has a height and width, and extends above the plane of the retina. This is the ridge. Blood vessels enter the ridge and small isolated neovascular tuft may be present posterior to it. These are known as popcorn lesions. This is extraretinal fibrovascular proliferation or extraretinal neovascularization also is the stage 3. So in stage 3, there can be mild, moderate or severe forms. There is a flat neovascularization in zone 1 is considered stage 3 even when actual ridge does not exist. Here there is a neovascularization in the first figure, and in second figure there is a pre-retinal hemorrhage here, which suggests that there may be a new vessel present there. So retinal detachment, that is a stage 4. So loss of fine details of choroidal vasculature or granular pigment epithelium or a ground glass appearance, that way only we can identify whether it is detached or attached retina. And macular ectopia, straightening of arcade vessels, these are also signs of peripheral traction. So stage 4, it can be exudative tractional, treated, untreated, varies depending upon the tractional vectors and exudation. So stage 4 main is stage 4A and stage 4B. Stage 4A is fovea attached, stage 4B is fovea not attached, detached. Okay, and this is the partial retinal detachment. It may be exudative or tractional. Exudative within days post laser. It may be convex, localized, and self-limited. Tractional, it is progressive fibrovascular organization and vitreous haze, and sometimes subretinal heme and lipid may also be there. So stage 4, so stage 4A and stage 4B. I know we cannot see a lot in this, but here the fovea is attached, and here you can see the fovea is detached. But if you have more confusion, then you can also do OCT. I will get back to it. This is the volcano-tractional detachment. It occurs in AROP, that is aggressive ROP. Detachment generally involving the fovea, means the peripheral retina remains attached. Normally, what happens that peripheral retina gets detached and then the central retina will be detached. But here, this due to it is aggressive ROP, fovea is detached and peripheral retina is may be attached. It is attached, and technically it is a stage 4B periphery attached retina. Sorry, classification. And this is the role of OCT in stage 4 ROP. So OCT accurately shows the foveal involvement, whether the foveal involvement is there or not. So here you can see that the fovea is not involved, okay, in this RD, but in this the fovea is involved. So this is a stage 4A ROP and this is a stage 4B ROP. So stage 5 is total retinal detachment. So yeah, this may be a little bit confusing, but just understand that if the optic disc is visible, then it is 5A. Optic disc is not visible due to fibrous tissue or it may be closed funnel RD, then 5B. And 5C is when there is a 5B RD, but there is a anterior changes also are there, like anterior lens displacement is there, or anterior chamber shallowing is there, or iridocapsular additions are there, or capsulo-endothelial lesions with central corneal opacification may be there. So, can anyone tell me what is this ROP stage without? Yeah, so this is stage 5. This open, closed, closed, open, closed, closed. These are the funnel configuration. Means total retinal detachment will be there. So open means it is open both anteriorly and posteriorly. Open closed means anteriorly open, closed posteriorly. Closed open means posteriorly it is open and anteriorly it is closed. And closed means anteriorly also it is closed and posteriorly also it is closed. But this I think so it will be more clear in US scan. Plus disease and pre-plus disease signifies a tendency to progression and is characterized by dilation and tortuosity of blood vessels involving at least 2 quadrants of posterior fundus. So if this is not there, then it will be pre-plus disease. Okay. Other features like failure of pupil to dilate and vitreous haze may also be present. Pre-plus disease is defined as abnormal vascular dilation and tortuosity insufficient for plus disease. Okay, so less than 2 quadrants, then it will be pre-plus. More than 2 quadrants, then it is plus. And there are types of plus and plus disease also made it. So aggressive ROP. So first it was known as aggressive posterior ROP because we thought that it will occur only in posterior it may occur but in the posterior part of posterior zone only, but it may occur beyond the posterior retina also, and larger babies in developing countries may also get this aggressive ROP. Hallmark is rapid development of pathological neovascularization and severe plus disease without progression being observed through the typical stages of ROP. Early cases, capillary abnormalities posterior to the original border of vascularized retina, such as arteriovenous shunting, resembling dilated vascular loops surrounding areas of vascular injury, and there may be also flat neovascularization. So these are the pictures of. So these are the common terms which are used in clinical trials to describe the acute ROP. So so there is a threshold disease and pre-threshold disease. In pre-threshold disease, there are two, type 1 and type 2. So threshold disease, you can remember like that there is a stage 3 disease, extraretinal neovascularization, either 5 contiguous clock hours or 8 cumulative clock hours in the entire fundus. Retinal vessels ending within zone 1 or zone 2, and plus disease. These three things should be present, then only it is threshold disease. Otherwise, it is not a threshold disease. Pre-threshold disease, all zone 1, zone 2 changes except zone 2 stage 1 and zone 2 stage 2. What is zone 2 stage 1? Demarcation line zone 2. And zone 2 stage 2? Reach. Without plus disease that do not meet the threshold criteria, treatment criteria, are subdivided into type 1 and type 2 disease. So type 1 is zone 1, any stage ROP with plus disease. Means in zone 1, if any stage of ROP will be there, that is zone 1 and 2, stage 1 and 2, with plus disease is present, then it will be type 1. Zone 1, stage 3 ROP without plus disease will come in this, because with plus disease, then it will be this only. Because if flat neovascularization is there, and this 5 contiguous clock hours and accumulation, then it will be that only. Zone 2, stage 2 or 3 ROP with plus disease is also type 1. So it is better to remember type 2 because it is easier. So it includes only zone 1, stage 1 or 2 ROP without plus disease, and zone 2, stage 3 ROP without plus disease. Type 2 will only involve.
Show the photos, it will be difficult. Did you understand this whole slide? It's going above the head.
Okay, sir.
Exactly. Okay. So in general, zone 1 is scary zone or relaxing zone? Scary zone. So the column you take that, not this one. You open.
Yes.
Let me just come back 1 minute.
Okay.
You start like that. The retinal vessel starts here. Is told about that vasculogenesis and angiogenesis, correct? The vasculogenesis starts, angiogenesis starts with protein the vessels. It reaches up to one level, okay? Once it reaches one level, it just stops there. When you stop, you have a demarcation. So when the vessel stops, the first stage will be demarcation. That much is simple, it should just remember. Okay? So vessel stops there, it doesn't go further, it doesn't know what to do. There's no stimulus for that side for the vessels to reach it. What does it do? It starts elevating from the surface of the retina. Okay, it just takes a turn like that, like a hump in the road. Okay, the hump in the road is called stage. Okay, ridge formation. It cannot go further. It's a roadblock there. So the stage 2 is the ridge. Still the nature takes care, okay, ridge is avoiding the next level too. So the disease has to progress. Over the ridge, what happens if you go over the hump suddenly in your vehicle? Just take a step. So the vessel starts reaching the vitreous cavity. So what is that called? Extra. Nothing but, like when you see in diabetic retinopathy, what happens? The fibrovascular proliferation, what we term, the same fibrovascular proliferation starts lifting onto the vitreous side. Why any vessels in the retina, when it starts from the retina, it goes to the vitreous? Why? Any disease, there is only one explanation for that. We call it as a scaffold. Scaffold is nothing but like a culture media for a bacteria. Vitreous has got all the nutrients in. So when there is a deprivation on the retina, it reaches the vitreous. Okay, so any disease, you take a diabetic retinopathy, you take a hypertensive retinopathy, you take a FEVR, whatever the disease you see, the retinal vessels, when it is not having its accessibility in the retina, it has to reach the vitreous. Okay, that stage is called. So once it reaches, again there is no control. The disease goes up and up. What happens? The vessel reaches somewhere. Okay, it's like a plant in the small pot. It has to reach one level. After that, what happens? It does not have a support. Okay, so what happens? It does not have a support. The vitreous is a scaffold. It starts giving it more of a fibrotic phenomenon. Okay, the tender vessels will form a fibrosis. Okay, the next stage. So the vessels takes the retina and then pulls to the vitreous cavity. That's called retinal detachment stage. So when it is in the corner in the zone 3 area, so it's called 4A because it starts here. See the vessel, the radius form, the vessels is coming up, and the white color became fibrosis. The vessel will always, even in diabetic retinopathy, the same thing happens. The vessel will be red first and then cause the fibrosis. Correct? That's why fibrovascular proliferation is called. So the vessel starts, it pulls the retina, it causes detachment. And the detachment again starts in the periphery. That is why at stage 4, 4A, 4B comes. 4A is, it is just here, it's not reaching the macula. 4B, when it starts completely pulling it, it involves the macula, that is 4B. Okay, next, still it goes beyond that. Beyond that, what happens? Stage 1 means retina has now started pulling the temporal area, the zone 3 crescent, you remember? Zone 3 crescent, that area if it starts pulling, the force is so much, it starts pulling the nasal retina also. Nasal retina, actually the vessels has already reached nasal, but the traction does not stop there, it starts like a ring. Okay, so ring starts. So that's why all this terminology comes. It's like folding of your cloth. Correct? The folding of your cloth, you start from the periphery and try to reach the anterior. So when it starts doing that, initially it will be open. It will be just a ring. Okay? And then it starts closing itself. So then it becomes open, closed. It will be open down, but it will be closed up. Why it closes up? Where the traction is there? In the zone 3 area. Zone 3 area is having more of a vitreous base, correct? The vitreous base which is more very strong. So it starts pulling. It's like a, anyway, you would have seen the OT dress where we put on top. So inside it will be hollow. If you close the upper one or a plastic cover, it becomes closed, but there will be a hollow inside. That's called open and closed. Okay? Or sometimes it can take an opposite fashion. Close, open, and last will be the close. So when there is nothing, when you are not treating it, when you are not cutting the disease there, finally the whole retina from down to up it becomes. I asked you to put that photo there. So that's what the last photo is. So you can see the posterior retina which has come to the anterior part. Okay. So the whole retina is like a twig rod, and you are seeing that retina in the behind the lens. Okay, what is behind the lens word? Retrolenticular. What is fibroplasia? That is the origin of the ROP word. What was called retrolental fibroplasia was the initial word because they all used to see only the vessels behind the retina. Okay, so that is the stage 1. So now we go back to this one. This is nothing, you don't need to remember all these things, these are all beyond that, even we don't want to remove it. But what is important? You asked me what is acute ROP, right? Acute ROP means something you need to treat, that's it. Okay? Stable ROP you need not treat. Acute ROP means zone 1. So whatever you see here will be zone 1, zone 1, zone 1. So whatever the disease, if it is in zone 1 and stage 3 is fibrovascular proliferation. So these are the two things you need to remember as an acute. When the retinopathy ROP needs treatment, it should be zone 1 and it should be stage 3. Okay, this is the follow-up.
Yeah, follow-up. After each patient evaluation for ROP, disease features dictate the follow-up interval. So follow up maybe 1 week or less, 1 to 2 weeks, 2 weeks or 2 to 3 weeks. So if there is immature vascularization and no ROP, if it is in zone 1 or immature retina extends into the posterior zone 2, then 1 week or less we will do. If it is posterior zone 2, then 1 to 2 weeks also is okay. If it is in zone 2 only, immature vascularization, then 2 weeks is also okay. Then ROP stage 1 and 2. So stage 1 and 2, zone 1 always 1 week or less. Zone 2 it is like 1 to 2 weeks. Uh, Stage 2 zone 2 and stage 1 zone 2, that is like demarcation line, that will be 2 weeks. And zone 1 or 2, that is in zone 3, it will 2 to 3 weeks is okay. ROP stage 3 always 1 week or less you have to follow. So zone 3 and zone 2 and pre-threshold disease, this all will come in. Means we should do 1 week or less. Understood? It is easy. See, in immature vascularization, like everything in zone 1 will be 1 week or less, zone 2 will be 1 to 2 weeks or 2 weeks, and zone 3 will be 3 weeks. Like that, you
Same
understand.
algorithm you will get that. So anything beyond stage 3 is scary.
Stage 3 is
Anything at zone 1 is scary.
Hmm.
So what is scary, you need to follow
Follow
up
up
faster.
early.
What is little scary, you follow it up little slower.
So management, there are three things: laser, anti-VEGF, and surgery. Observation only if not meeting the treatment criteria. So which laser do we use for ROP? Anti-VEGF injection and surgery. Surgery will involve scleral buckling, lens sparing vitrectomy, and lensectomy plus vitrectomy. So these are the clinical trials. There is a cryotherapy. Before there was no laser, so there was a cryotherapy for retinopathy of prematurity. It showed unfavorable. Main conclusion from this study was that unfavorable structural outcomes occurred in 48% of observed patients versus 26% of treated patients. So when we treat, less percentage were having unfavorable structural outcome, and unfavorable functional outcome occurred in 56% of observed eyes versus 35% of the treated eyes. Then early treatment, retinopathy of prematurity study, that is ETROP. So it included earlier treatment was associated with reduction in unfavorable visual outcome from 19.5% to 14.5%, and reduction in unfavorable structural outcomes from 15.6% to 9.1%. Actually, in CR cryo ROP, only threshold disease people only they treated. Sorry, babies only they treated. And in ETROP, type 1 pre-threshold and threshold both were treated.
Why
So,
it was like that? Nobody knew what was the disease.
Yes, sir.
Okay, 1987. There was no treatment for anything except for cryo. Even for when you take a diabetic retinopathy or whatever treatment, there was no laser available. Okay, so the only thing was the cryo. Even for diabetic retinopathy, the cryo treatment were there. So cryo used to take off the or ablate the retina, what you call, and hypoxia to anoxia. Okay. So the cryo treatment started, and when there was no investigation we could not even see, there was the deficiency of even indirect ophthalmoscopy. So the baby had to completely come to the stage 5 to see that, and then you start the treatment. That's how the treatment started with cryo. And then when the laser came in 2002, then these trials of EPROP. Why I am telling you is that in case if there is a question asked for what are the trials in ROP, you can just think of all these things. Just start from the remote thing like cryo, then laser, then third thing is
anti-VEGF.
Yeah, B means B. B means bevacizumab, that is Avastin. Avastin was the first anti-VEGF which was started, correct, which came into the home. So you can remember like that. First was cryo, then comes the laser trial, then comes the Avastin trial called bevacizumab, that is beat ROP. Rainbow word signifies R is ranibizumab. So
Yeah.
So the
So
heading, if you remember, also is
Yeah,
more than
okay.
sufficient. You don't need to go beyond that.
So
One more is there, or that's all?
yeah, only I included
What are the
four.
other anti-VEGF which are there apart from the ranibizumab? You know? Yeah, what is it called? Okay, so there is two trials on that now. What are the two trials? Some Eylea types of some fly. What is butterfly? And one is firefly.
No.
Just remember that because it came into the same cryo, then laser, then bevacizumab, then ranibizumab, then IVI. Okay, if one question comes, you can write now, right now. Rest of the things you can put it up.
So laser. So indications are aggressive ROP, mostly combined with anti-VEGF injection, threshold disease, and type 1 pre-threshold ROP according to ET-ROP. So type 1 again I am brushing it up. So zone 1 any stage of ROP with plus disease, zone 1 stage 3 ROP without plus disease, and zone 2 stage 2 or 3 with plus disease. Okay. And in AROP, we need it is aggressive ROP, so early initiation of treatment is preferred within 24 to 48 hours. So what are the prerequisites of laser or any like intuitive also we are giving them this only. Informed consent should be taken of the parents. Baby will not be able to be. So set up NICOOT, vitals monitor under anesthetist, pediatrician with suction apparatus, resuscitation and all that should be there. Equipment, what we require is laser indirect ophthalmoscopy, condensing lens, scleral depression, that will be the Vectis and Alfonso speculum, preferably autoclave. It should be autoclave only. Drops, ROP drops and Paracane should be applied, and topical. It can be topical anesthesia or general anesthesia, and baby should be covered properly. So it should be temperature controlled and clean environment. OT. Pupil should be dilated. That I have already covered, and avoid repeated use of dilation drops because systemic absorption may be there. Phenylephrine we are using, so it may cause fetal hyper tachycardia and all that. So equipment. So this is the laser machine connected with the indirect ophthalmoscope. This is the Alfonso speculum, and this is the Vectis, which is used for depression, and this is the 20D lens.
Do we have a name for this Vectis? Yeah. People should be knowing that is kept as an instrument.
Vectis.
Alfonso speculum, like any other universal speculum, will be kept. But Vectis is kept because that comes under for your cataract surgeries also.
Why Vectis?
You will have to. That's asked.
Yes, sir. Okay.
By the way, one point I wanted to informed consent he told, right? So now you understood the ROP. There are two things only in the ROP. ROP is preventable disease or non-preventable disease? Preventable. ROP is a hereditary disease or acquired disease? Clear? That these things should be told to the parents first. Okay, as an ophthalmologist, these are the two things which we need to tell the parents. Okay, then only the importance of the disease will come. It's a preventable disease. We can prevent the disease. We do not allow the disease to go. It's all under our hands of the doctor. And it's not a hereditary disease. These are the basic things which they will ask you and they will be expected. So this should be very clear.
So preparation of the baby means the ECG leads and all that should be connected, and this is the incubator. Okay, so settings. The entire avascular retina anterior to the ridge up to the ora should be the target area. Power and duration. So initial power depends on the pigmentation. 150 to 200 with yellowish burn is generally preferred. Power is titrated working from the anterior to the posterior retina in order to prevent retinal breaks. So we will go from periphery to posterior pole. Not for posterior pole, but yeah, posteriorly 100 to 300 milliseconds near the exposure time. The interval should be near confluent burns between the retinal burn, laser burns. 3000 to 4000 per eye in case of zone 1, posterior zone 2, and 1000 to 2000 in zone 2 or 3 disease. In one setting, multiple settings based on surgeon's comfort and general condition of the baby.
So the four parameters of any laser, okay, can it be exposure laser or retinal barrage laser or whatever the laser. The four parameters you are supposed to know. One is power. Okay. Power for glaucoma lasers are different, retinal lasers are different. You just can make one small notes of only the laser or in the FAQ book is there. And power is important.
Exposure.
Exposure interval, these two are little brother sisters. Both will be on. Just if you want to just put a goalie and 100, 200. And even if you don't understand, you just have to tell 100, 200 is the average for both. exposure and interval. Just remember that. Power is based on what you put the power. Okay. And anything again, it's a little logic or common sense. Babies, how much power we require, and adult, how much power require? Common sense. Correct. So in case if the diabetic retinopathy has got 200 power, for the babies you can just use a little common sense and make it into 100 power. 100. Right? That one is clear. And the number of burns. Anybody has how much PRPs when we do what are the burns? Just a guess for diabetic, proliferative diabetic retinopathy, PRP. How many burns we put? Read that because the burns is nothing but the area covered. Okay. If I have to cover this wall, how much burns I will take? I will take X number. If I have to cover only this part, how much I will take? Less. I take lesser part. Okay. So that's it. For diabetic retinopathy, you have to cover the whole of the retina. So it numbers goes in thousands. Okay. And for ROP, it is again, it's a huge area. It's a huge area. See that zone 1. If you start from zone 1 is almost like a macula. So this zone and our diabetic retinopathy, again, both are same as far as anatomy is concerned. So the area you have to cover that much, it requires at least in one sitting at least 1000. So diabetic PRPs will be 3000 for 3 settings. And the same thing what he applies here also. Okay. So this is more of again a common sense when you suddenly have to write something on the lasers. These are the 4 parameters. You should just can use your logics and then start writing. So interval duration will always be combination. Same thing. It won't change. So these are the pictures of laser ROP babies. Follow up after the laser after a week or two, depending on the zone severity of the disease as we discussed. Look for regression, traction. When they come up for follow up, what we will look for regression, traction, or reactivation. Endpoint is when vessel crossing the laser marks or complete vascularization is done, then it is the endpoint. So now anti-VEGF injections. So indications is aggressive ROP zone 1 or zone 2 when the laser is not possible in pre-op injections, and rescue treatment also we can use it. So this is very important. Half the adult dose you have to use. We use for adult dose 0.05 ml. So you have to use 0.025 ml of bevacizumab or ranibizumab or aflibercept also. And the can anyone tell me what is the distance from limbus for phakic and pseudophakic patients for anti-VEGFs? Normal adult. Yes. Normal adult. Yeah, 3.5 for pseudophakic, 4 for phakic, and 3 mm for phakic. So this will, because it is a baby, so it will the development will not be completed. So 0.75 to 1 mm from the limbus under topical anesthesia, aseptic precautions should be taken care of. Post-injection care, close and prolonged follow-up is required because post anti-VEGF injections, maximum chance of recurrence is there. Recurrence and peripherally vascular retina, maybe the laser. So we can do laser for rescue. And complications include invasive or crunch phenomenon. Okay, this is a technique. Yeah, so we'll mark with the caliper. One mm only, you can see, and then that's not 0.75 now. Yes, sir. That is much more than 3 You are cheating your audience here, no? Showing wrong things. Yes, sir. 0.75 is very small. Very small. It's just like one second you go and you reach that, it's a 0.7. It's almost point. This is much more. Follow up of after anti-VEGF injection. So post op day 1 to rule out any infection. 3 to 5 days in case of aggressive ROP, and follow up after 1 week for therapeutic response to and determine the need for additional treatment. What is crunch phenomenon? Acute contraction of proliferative membrane after intravitreal injection of anti-VEGF. Highest risk of late reactivation between 2 to 4 months after the injection. What is crunch? You got it now? Crunch is related to injection. Injection, not a disease. Okay. So laser versus anti-VEGF.
So laser, we need a good dilation of pupil. So this will be poorly dilating, hazy media, sick child, aggressive ROP, faster vascular regression. In laser, there will be faster vascular regression, but a lesser peripheral visual field loss and lesser risk of myopia and no visible scarring. In anti-VEGF, it is invasive. These are the disadvantages. Systemic VEGF suppression, reactivation and recurrence is there, crunch phenomenon is there, long follow-up is required, and persistent avascular retina may persist. What is persistent or not peripheral?
What did you?
Someone told peripheral.
No.
Yes.
That's where
I thought that it persistent only. Laser can be used as a rescue treatment for reactivation.
So when you see this slide, then why can't we take off the laser and then give only the injection? No, no. Laser is like do three settings with so much of area. Injection is you just give one injection. What does injection do? What does laser do? We didn't tell that only. Start with laser. What does laser do? Same principle again. Hypoxia to
hypoxia to anoxia.
So that's what he told. After the laser, what the vessel starts going into that area. Vessels which had stopped there will start going into the normal area. I mean, the lasered area and reach the oval area. Okay. So the whole. So again, anti-VEGF. What does it do?
It will cause inhibition of neovascularization. So
Inhibition
that
of new vessels.
yeah.
So what happens?
So vessels will not grow only.
Vessels will grow. The new vessels will stop.
Normal vessels grow and new vessels will not.
When the normal vessel grows, it's such a magical injection. Okay, then laser treatment should not be a treatment, right? Okay. Any differences there? No, beyond that, beyond for these people. What I'm trying to differentiate is should not take away with that impression that laser and injections are equal to treatments. You can opt for this. Okay, I will opt, nothing like that. Laser is always been, even for diabetic retinopathy. Why still we are doing that laser? We have got so many anti-VEGF. If the laser would have been taken over by anti-VEGF, you would not have done the laser by anybody. The laser should have been extinct. Okay. So the explanation is the laser has always been a gold standard and the proven treatment for that disease. Okay. And whereas the anti-VEGF is a chemical change which is going to happen, which may not last long. Okay.
So now surgery. So stage 4 and stage 5. So for stage 4A, scleral buckling with only peripheral traction, only peripheral traction retinal adjustment will be there. So scleral buckling may be enough. This procedure can be combined with cryotherapy or laser to any peripheral persistent new vessels. Encircling band needs to be removed once the child is 1 year of age to allow normal growth of eyeball and to reduce the amount of anisometropia. So this is lens sparing vitrectomy. So lens sparing vitrectomy has shown promising results in stage 4A and stage 4B. So we use 25 gauge vitrectomy in children's in babies is now common use for ROP surgery. And so this is the stage 4 peripheral retinal retracement and this partial. This is the stage 4A, stage 4B. So lancectomy and vitrectomy both are required. The aim of the surgery for this is the surgery for stage 5 ROP. You have to just remember that in stage 5 ROP, surgical results are also poor, prognosis is also poor, and usually it involves a lens removal also. So see, this is the open configuration of stage 5. The optic disc is seen, so this is stage 5A. This is closed funnel, and this one is also showing the closed funnel RD. This one, what is this one? This stage, anyone? This is the cornea also is involved and all that. So stage 5C. Okay. Regression, reactivation, and late sequelae. So we'll cover this first. Regression is reversal of reversal plus downstaging of disease, and then there is normal vascularization. So regression may be complete or incomplete. So early signs are vascular, means early faster post anti-VEGF, that is 1 to 3 days, and 7 to 14 days after laser. Reduced plus disease and reduced dilation and dilation will be reduced more than tortuosity and uncoupling, thinning, whitening of the neovascular tissue, and vascularization into peripheral retina, that is the complete or incomplete, and if it is incomplete then it will be persistent avascular retina. Regression of tunica vascular lentis, good pupillary dilation, improved media clarity, and resolution of intraretinal hemorrhages. These are also the signs of regression. Here you can see after the laser the disease is regressing. Uh, so reactivation. So reactivation, I told you that post anti-VEGF it is a maximum chance and spontaneous, and if you do proper laser then it is the reactivation is the minimum chances. Commonly reactivation is followed for injection after occurs following injection occurs at 37 to 60 weeks post menstrual age, and signs of reactivation include recurrent vascular dilation tortuosity or both, like pre plus or plus disease, and there may be demarcation line or ridge again appearing, and reactivated stage is more in more anterior zone. So reactivation post anti-VEGF injection. Yeah, see here you can see the ridge. This is a demarcation line. And the vessel tortuosity also is dilation and vessel tortuosity.
That is the difference between the anti-VEGF and the laser. See the reactivation.
Yeah.
What do you mean by 60 weeks? 60 weeks is how much? What's the month? The baby month.
5 months.
5 months. So when you give a small one injection, so the disease can come into back to its effect again at 5 months. At that time you would not have supervised babies. Okay. So the difference between the laser you have a control, you have a demarcation, like you know it is going to work and it is going to stop. Whereas the injection you cannot predict the disease. That's the major difference.
Yeah.
Okay.
To discontinue screening. So this one, when there is for us, it is like full retinal vascularization, then we should stop screening. Zone 3 retinal vascularization attained with previous zone 1 or zone 2 ROP. The post-menstrual age of 45 weeks and no type 1 ROP or more severe ROP. Post-menstrual age of at least 65 weeks in patients to whom intravitreal anti-VEGF medications caused regression of ROP, and regression of ROP is signs of regression of ROP are there. So long-term sequelae, there is a late retinal detachment that can be rhegmatogenous, fractional, and rarely exudative. Okay. Tractional schisis, persistent avascular retina can remain. Macular anomalies like a small foveal avascular zone, blunting, absence of foveal depression. Retinal vascular changes may persistent toxicity, straightening of vascular arcades with macular dragging and falciform retinal fold. Glaucoma, secondary angle closure glaucoma can occur. Others are myopia, anisometropia, strabismus, amblyopia, cataract may also occur. So here the first image is showing persistent tortuosity, and there is a ridge-like structure here. And in the second, straightening of the vessels with disc drag with pigmentation is there. Okay. So this is a photo of lead sequence. These are my references, and these are the previous year questions. All the questions are mostly on risk factors and classification. Management, yeah, we can write from my PPT only. But risk factors and classification, all of them have asked. See, indications and principles of therapy. These are DNB and MS both questions.